All right, welcome everyone. In this explainer, we're going to build your understanding of respiratory nursing right from the ground up. This is for you, the nursing student, to really help you sharpen that clinical judgment, starting with the absolute basics and taking it all the way to complex care.
Okay, let's get into it. Here's our game plan. We'll kick things off with how a healthy lung works, then we'll jump into assessment and diagnostics. After that, we'll look at what happens when breathing fails, cover some key conditions you'll see all the time, and wrap up with the core nursing interventions you need to know.
All right, first things first. You can't possibly understand what's wrong if you don't know what right looks like. So we've got to start with the fundamentals of how a healthy respiratory system is supposed to function.
So, ventilation. What is it really? Think of it simply as the mechanics of breathing. It's the physical act of moving air in and out. Your diaphragm drops, your chest expands, and you pull air down into those tiny little air sacs, the alveoli. It's all about getting the air to the party.
Okay, so you've got the air. But that air is pretty useless if there's no blood there to pick up the oxygen, right? That's where perfusion comes in. This is the blood flow part of the equation. The heart pumps blood to the lungs so it can grab that oxygen and get it where it needs to go. And this is where it all comes together. It's this beautiful partnership. You need the air, the ventilation, and the blood, the perfusion, to be in the same place at the same time. We call this the VQ ratio. A perfect match is the goal.
Okay, so we get the ideal VQ match in theory. But how do we, as nurses, actually figure out what's going on at the bedside? How do we know if our patient has an air problem, a blood problem, or maybe both? Well, it all starts with your assessment.
Look, a good assessment isn't just a random checklist. It's a system, a story you uncover step by step. We talk, then we look, we touch, and finally we listen. Every single step adds another piece to the puzzle of what's happening with your patient. Seriously, before you even touch your patient, just look. Are they leaning forward, using their neck and shoulder muscles just to get a breath in? That is a massive red flag. Is their skin getting that dusky, bluish tint? That's cyanosis. Your eyes can tell you so much before you do anything else. And this is so cool. When you put your stethoscope on their chest, the sounds you hear are like clues to a mystery. Hear crackles? That's fluid. Think pneumonia. Hear a high-pitched wheeze? That's narrowed airways. Think asthma. And if you hear stridor, that is a medical emergency. That's an obstruction, and you need to act fast. So our assessment gives us some really good clues, but to get the definitive answers, we need to look under the hood. Diagnostics give us the hard data to confirm what we suspect and really guide our next moves. You know that little clip on the finger, the pulse oximeter? It's great, but it only tells part of the story. It tells us about oxygen, but what about carbon dioxide? Is the patient getting rid of it? To get the real picture of gas exchange, we have to look at the blood itself. Okay, these numbers right here, this is the holy grail of respiratory care. You absolutely have to know these by heart. Let's go through them. pH, normal is 7.35 to 7.45. PaCO2, your ventilation number, is 35 to 45. And bicarb, your metabolic number, is 22 to 26. Commit those to memory. Now, I know interpreting these can look super confusing at first, but here's a little trick that's going to save you. Just remember the word ROME. It stands for respiratory opposite, metabolic equal. If it's a respiratory issue, pH and CO2 go in opposite directions. If it's metabolic, pH and bicarb go in equal, or the same, direction. It's that simple. So, what happens when this whole system, this delicate dance between air and blood, just fails? When the body just can't keep up anymore? You end up in a life-threatening situation called respiratory failure. And really, it boils down to two main ways breathing can fail. You got to ask yourself, is this an oxygen problem or is it a carbon dioxide problem? Type 1 is an oxygenation problem. They can't get enough oxygen in. Type 2 is a ventilation problem. They can't get CO2 out.
AIRDS, man, this is one of the scariest things you'll see. It's a severe type 1 failure. And the key phrase you need to burn into your brain is refractory to oxygen. That means you can crank up the O2, but their sats just won't come up. It's a sign of profound lung damage.
Okay, with that foundation in place, let's start applying it. Let's talk about some of the big hitter respiratory conditions you're going to see all the time as a nurse. Asthma and COPD. You'll see these constantly, and people get them confused. Here's the one word that separates them: reversibility. In asthma, the airway constriction is reversible. With COPD, that damage is permanent, and unfortunately, it's progressive.
Okay,
Pay close attention here. These are the red flags for when an asthma attack is turning deadly. This is not a wait-and-see situation. The patient is working way too hard to breathe. They can't even talk. They're tiring out. This is a medical emergency.
And this right here, this is maybe one of the most important things you'll ever learn about asthma. If you've been hearing that classic wheeze and then suddenly there's silence, that is not good news. It's a 5-alarm fire. It means so little air is moving it can't even make a sound. You need to prepare for intubation.
Remember VQ? Well, a PE is a classic Q problem, a perfusion problem. There's a clot blocking blood flow. Patients are often terrified. They feel like they're going to die. Your very first job is to get oxygen on them, stay calm, and reassure them.
All right, enough theory. Let's get to the practical stuff. The what do I actually do about it part of nursing. These are the core interventions you'll be using for your respiratory patients.
If your patient has a chest tube, this little 5-step check should become muscle memory. You do it every single time you walk in that room, no exceptions. Check the dressing, the tubing, the drainage, look for titling, and check for bubbling, every time.
And with chest tubes, it's all about knowing what's expected versus what's a call the doctor right now emergency. A sudden gush of bright red blood? That's a call. Continuous bubbling a few days after insertion? That's a new air leak. That's a call. You have to know these red flags.
Listen, a trach is a surgically created airway. It is a direct line to the lungs. There is no higher priority than keeping that airway safe and secure. It's all about being ready for the worst-case scenario, which means having a spare trach and an obturator at the bedside, always.
So let's bring it all home. What are the big takeaways? 1. Ventilation is air, perfusion is blood, and the VQ match is everything. 2. Your systematic assessment is your bedrock. 3. ABGs tell you the real story. 4. Know the difference between oxygen failure and CO2 failure. 5. A silent chest is a pre-arrest sign. And 6. ABCs always.
So I'm going to leave you with this question to think about. It's not about what you know, it's about what you do. Your patient suddenly can't breathe. Everything you just learned boils down to this moment. What is your very first move, and why? Always be asking yourself that question.